For our final session of the day, improving patient support and involvement in care. We're very lucky to have Neve Gallagher here, Fight Bladder Cancer patient representative, and Tracy Staskovich, bladder cancer carer and co-founder of Fight Bladder Cancer. So over to the two of you. Feel free to introduce yourselves and then discuss some of the points of interest. Next slide, please.
Hi, I'm Neve Gallagher. So I've been a bladder cancer patient for 2 years. I was diagnosed in May 2019. My diagnosis wasn't straightforward at all. So I would have been 47 at the time. I was more diagnosed as I had active bladders, what my GPs thought I had, and then it's quite complicated, really. I was running to the GP probably for a good year because. And then also at a certain stage, I came off the pill, the contraceptive pill. So that's when I thought I was having my period or whatever. So that I would have had hematuria probably for quite a while. And I had severe abdominal pain as well, which wouldn't have been unusual for me, my whole life from a teenager having periods. So my diagnosis really wasn't that straightforward. I wasn't on antibiotics for UTIs or anything like that. Also, I'm a pediatric nurse, so to be honest with you, it's helped me get through the other side. But at that stage before diagnosis, maybe between me and my GP didn't really know me until I was running into them, with my bladder cancer or whatever was happening to me. So, and then they knew I was a pediatric nurse, so I was working nights, probably stick my urine a few times, I'm sure, things like that. So when you're in night duty, you put everything pretty much down to nights. It's because I'm on night duty, I'm tired. So my diagnosis was really not straightforward. Busy, I've got 3 children and all the rest of it. So probably didn't take a lot of time to think about myself either. And it was my colleagues at work that were basically said to me, you need to go to A&E because my GPs had me red flagged. Someone somewhere had triaged me for a continence clinic, or as my sister-in-law calls it, an incontinence clinic. So so I had a fluid balance chart which I had to fill in over 3 days, and this was in the middle of, I was excruciating pain. I was on serious painkillers. Nothing was happening. The GP said, "I'm really sorry." Waiting lists being what they are in Northern Ireland, I was waiting for. I was red flagged probably several times. So then doing this fluid balance chart over a weekend just really wasn't going to get me any answers. So I went to A&E. They told me, seeing the blood in my urine, that it was urology. It was a urological problem. It wasn't a gynecological problem. And then they sent me home with the painkillers and said, "We're going to red flag you again for urology," which I knew meant outpatients. So I wanted to be admitted, but it wasn't going to happen. So over 2 weeks, I took myself to my GP twice. They were like, "Really sorry, we can't do anything. Our hands are tied. You're on a waiting list. We don't know what else to do." So eventually got seen within 2 weeks. So it was my second. I knew, being a nurse, that was my second referral to A&E. So they took me in. There happened to be a urology consultant in A&E at the time on a lunchtime on a Friday evening, and he took me over to the urology unit, Thorndale, and he was able to do a scope there and then, and he said, "Yes, it's tumours." So that was the day I went without my husband. But they were, to be honest with you, my problems all were, once I got my diagnosis, everything was a lot better. So this really helps for a summary of the key findings. I can relate to quite a lot. So once I had my diagnosis and I had to tell my family, and it was, the physical and psychological impact, I probably coped quite well at the time, to be honest with you, but it was coping with everyone else's feelings, and being able to go in and tell my mum, especially, I suppose, that I was going to have a complete hysterectomy as well as having the bladder removed. I've got quite a large family. I've got quite a lot of work colleagues, so no one knew about bladder cancer. Even me being a nurse, I have worked in children's hematology quite about over 10 years ago. So I worked with children who had cancer, but I did not for one second know anyone with bladder cancer or think it was going to be related to me. So physical impact, I actually think it's only hit me now, 18 months later, to be honest with you. And that's all with the talk of hysterectomies as well. I still don't know what I'm supposed to be expecting, even though it was a year and a half ago. But really, it would have been just, that's the main thing for me. I think also just obviously to talking to my husband and having to speak to him and talk about all that as well. And my children, they were quite good actually. Just the idea of, the mummy having a stoma, they were sort of funny about it. Tell me it was a bit gross, but they were okay about it. They were a bit grossed out. They would have been 8, 10, and 12 at the time. So my son, who was 8 at the time, just referred to the stoma as, oh yeah, that wee willy thingy that you have. So yeah, that's how my children cope with it. So that's fine, really. So speaking about access to peer support, early access to peer support, I actually have done that for someone else, but at the time, I started off in Craigavon Hospital, and then I had to go to Belfast City Hospital because this is our regional hospital for having RC. So I had the radical cystectomy by October, which is quite a long time from May till October. I actually was just openly said, because they kept telling me, you're quite young for having this and being a female and everything. So I said, look, if anyone needs to speak about having this, I have no problem. So I think it's because I really would have loved that myself, just even in the early days for me, and also for trying to explain it to everyone around me. I was very open about it, and I spoke to everyone, because that was obviously the days before COVID. So I had quite a lot of visitors and phone calls and all the rest of it. But it would have been really good just for me to be able to say to my family or my husband, even my friends, take this bit of information and go and read it, or go to this, even directing them. Because at the time I was coping for everyone else, and whereas now I do have the information because I know about bladder cancer. So there was at the time no signpost, and it is difficult. I know living over here for sure, no one knows about bladder cancer, and me along with Paula, who's my nurse specialist now from the City Hospital in Belfast, and we are trying to raise awareness, me very slowly, because I've actually only returned to work properly in the last 3 weeks. So it's like nearly 2 years. I had a few other complications, just things showing up on scans and things like that. And just with COVID, and I had 2 procedures which were slowed down because of COVID. So it seems like a really long time in terms of how hospitals are run when I was diagnosed, even though it was only 2 years ago. But there's definitely, there's no signposting here at all. My GP, I was in my GP so many times over that year, and I know every poster on the wall that was, breastfeeding, not bladder cancer, breast cancer, any of those. I know all the posters off by heart, and there was no bladder cancer posters. So definitely think that there's a lot of work to be done, especially over at our end. Okay, Tracy, over to you.
Thanks, Neve. So I'm Tracy, and I co-founded the charity with Andrew, I think 10.5 years ago, after he was diagnosed with a stage 4 bladder cancer. Pretty much didn't come home from the first test, so it was all systems go. And I think I've learned a huge amount about bladder cancer over the years. Andrew and I made it our mission because one of the key drivers of the charity is that knowledge is power. And as a patient or a carer, you feel powerless. And I think, touching on what Neve's already said, one of the reasons that there is such a significant impact on patients and their families when they're diagnosed is because they have probably never heard of it. And I know, other speakers today have already touched on this. And because they've not heard of it, everything is unknown. It's not like, oh, my friend's had breast cancer, you'll probably have this, you'll probably have that. And there are clear pathways. And the other problem is it's complicated. So within that pathway, there's a huge variety of options and choices and decisions that have to be made. So as Neve said, this accessing support and getting that clear signposting from that initial diagnosis is really key to giving people that first point of understanding of what they're coping with and finding their people. Because that's the other thing with bladder cancer, is it's incredibly isolating as a disease because nobody talks about it. So until you find your people, and you can find the Fight Bladder Cancer Forum or something like that, where you can ask all those questions that you just don't feel comfortable discussing with your medical team, you feel very alone. And it was really interesting to read the research findings because they certainly highlight themes that have come up over and over the last 10 years of the charity growing. And although, many patients do have fantastic CNSs and they are really well looked after and they really feel like they were well supported and understood what was happening, there are still far too many who didn't. And that has to do with many things, the lack of knowledge, that they don't know what they're going to expect, the difference across the country, things like that. And also that you're quite rushed when you're first diagnosed into making lots of decisions and you don't necessarily feel you have time to process all the information. So this is something that's really important, is that great communication. So you really do understand what's happening to you and you can make the right choices as you're going forward. And it's the understanding of the long-term implications as well. So when you're initially diagnosed, much of that initial conversation is about what we're going to do to get rid of the cancer or treat cancer now, without looking at the longer picture. And again, because people haven't understood about bladder cancer or heard of it before, they don't understand that unlike many other cancers, it has such a high level of recurrence, and often in a low level can mean repeated treatment over many years. So it's all of this information that we need to get to people and making them understand that they can question, giving them enough information that they can ask the right questions when they're presented with choices. Because one of the pieces of information that came out was that they didn't always feel they had a choice. And that's something that is really key in feeling that you've made the best decision for you and your family. And part and parcel of this, and kind of the last bullet point in here, is it's not just the patients. And as someone who spent many years as a carer, carers are the people who end up having to hold it all together. They're the ones where, when the patient is having treatment and is in hospital and has all the doctors and nurses, you're kind of on your own at home and waiting. And this is something that Johnston's touched on earlier. There's a huge amount of waiting around with bladder cancer, between treatments, waiting for test results, scans. It's a long process, and that's the time we really need to take care of people and make sure that they have support there. Because again, it is that information is power. And I think giving them a really good CNS, having them fully understand what's involved, asking the right questions makes a big difference. And giving the people who love them and who are affected in a different way their own support. So something that's quite often neglected with other large cancer charities as well is supporting the people who are supporting the patients. Can we do the next slide?
So healthcare professionals, that's probably one of the main things that happened to me. They need to signpost people, that are suspected or confirmed. So it wasn't even suspected. So if there were guidelines, then I would have been directed, and my GP would also be aware, just raising awareness that there are services for us, So I think that was one of the things for me. Because like I say, my main concerns with this was my whole diagnosis, because once I got diagnosed, I felt like I had a really good care between the two hospitals. But just thinking about other people that might have suspected bladder cancer, or they're confirmed, they don't know, they have no, I had a patient directed to me and I was fine with it, and now we're really quite good friends. I was her support rather than going to services that were, you know. And then actually, she had a choice. She had a choice of having a stoma, having her bladder removed. So I was happy enough for her to phone me. The thing is, though, I actually the next day texted her. I was worried because I made it sound like a really good thing, you know, to have your bladder taken out because I had such a good experience. Then I was thinking, you know, this is a really difficult position to be in. Where if she had services directly for her to be direct to from her GP, her diagnosis actually was quite a lot quicker and better than mine. So if her GP was able to direct her to someone for, you know, cancer patient services, that would have made a whole difference. So although I took it on board for myself that I was going to do this, for the onus was on me. So yeah, okay. What about you, Tracy?
So yeah, I mean, it must have been really terrible, actually. I do feel for you being a nurse as well, because I think that must have made it more difficult because you're in a position of kind of knowing, then you've got something that you don't know about.
Yeah.
But I think going to the second point, you know, it's that core understanding of what you're facing, and you don't have a massively long time to make some really life-changing decisions. And I think at that stage, patients and the people they love are often focused on getting rid of the cancer, you know, whether that's cutting it out or having this procedure or let's have BCG. And you're only really thinking about that. Whereas what we need to do is encourage a much wider discussion of what does that mean for the rest of your life? You know, how does that impact you? Your job, your health, your family, what does that entail? And I think particularly in the middle ground of bladder cancer diagnosis, this is really tricky, where patients are expected to choose from, you know, having their bladder removed or continuing treatment. And there's much grey in that area. It could be that they continue with a kind of lower level of treatment, if you like, for a longer period. But if you're in that boundary where it may come back and then you may be faced with having to have your bladder removed, or worse still, you've gone past that point, we've got to make sure that that information is full enough that they understand the ramifications of their choice. And that's really difficult. And I know it's something that the charity's been working on for a long time. And there have been big leaps and bounds in this. I know the new patient information booklets for each of the pathways give huge amounts of information, and also really practical information in plain language. And this is the other thing about communicating with patients. They will often sit in a doctor's appointment and have a chat with their healthcare professional team, you know, a good chat, they have a good relationship. But when they come on the forum, the questions they ask are about sex, pooing, how am I going to travel in the car, can I go on an aeroplane, like the weird everyday stuff. And I think those kind of discussions are really important, because for something like sex, you know, often for both men and women, it's a huge part of a change in life after bladder cancer treatment, but it's barely touched on in a kind of thorough way before the treatment begins. And it's not understanding that. And then afterwards, they often feel too embarrassed to ask about it, or they just assume, well, I'm alive, so this is how it is. And I think that's something that, you know, from the report we can gather it is still going on. So it's something we really need to talk about and encourage that conversation, normalize those bigger themes, so that you are talking, you know, sex, death and toilets in the end. And I think that by highlighting those big issues and giving patients an understanding of them, we can make the biggest difference overall. And that will bring the biggest change to bladder cancer patients as they move forward. And that's where the last point on, you know, getting that data on patient experience and quality of life is what should then guide us moving forward. Because, you know, the information that we have from the Exemplar study really shows that these are the key themes, and they do come up over and over. And so we must address them and make sure, by looking at the data afterwards and re-interrogating patients about their experience and their lifestyle afterwards, that it continues to see improvement. Because I think that's the only way they will really move forward. So shall we go to Our last slide.
So yeah, just to focus on developing best practice procedures for bladder cancer as opposed to other cancers, just to focus on bladder cancer. So this is bringing the bladder cancer community together. So they're going to be the experts who'll be able to develop these best practice procedures. So like I've been saying, you know, we all know patients who have breast cancer or bowel cancer, and so we need our own to be able to have our so it's a completely different way of looking at things, and that was the only support that I've had lately is speaking to people who have had breast cancer or until I find bladder cancer. But at home, the only people I know are people with breast cancer, bowel cancer, things like that. So to be able to bring this all together, and so that it's holistic as in it's everyone who's bladder cancer in the community, the bladder cancer community. So yes, there's something else I was looking at earlier. I meant to. Sorry. Yes, Tracy, over to you anyway.
I think you've covered most of it, Neve, to be honest. I think really it's just like looking at practical things that we can help support healthcare professionals with. So this idea of guides towards best practice that do include things like mental health, sex, lifestyle, all the things that really are about surviving bladder cancer. Because, you know, one of the things the report seems to pick up on is that there's a lot of activity in the treatment phase, but life after bladder cancer can be a long time. It can be a full life, but the decisions that you make early in your treatment will change the shape of that life. So by getting these guidelines put together, so best practice, not only for the patient, but also, you know, carers, family members. I think mental health is really important because particularly during the pandemic, you know, the support that has been needed on the Fight Bladder Cancer Forum has been much more in-depth because people don't have that face-to-face communication with people, which is such a good support. And I think it's looking at different ways that we can tell them as well that we have this support in place once this has all been pulled together.
I think, Tracy, that's what you put that more eloquently. Like what I was trying to say is the face-to-face with other bladder cancer patients, because my main support has face-to-face, you know, with other patients has been my friends, and none of them, you know, have bladder cancer. So yeah, that's what I was trying to say. Okay.
It's just about finding your people, isn't it? I think helping people find the people who understand what they're going through, whether it's the right people in their medical team or fellow patients, is key, because that input makes you understand that there can be life with this disease, or indeed after this disease, depending on your treatment. So
yeah, because I have to say that I really did feel that I really did have excellent support, and maybe it was also because I was a nurse both in Craigavon, you know, where I had my initial diagnosis. Like I got in that night and had my TRBT the next morning or the next afternoon, and then when I went to Belfast City, I really did feel like that up there, because it's the regional centre, that they really did understand, and also obviously because I was a nurse. Pediatric nursing is a whole completely different world from adult nursing, but I did feel like that was the closest I had to people that understood, even though I was the only patient. I was the only one that was a patient. Although Paul has been trying to get me to join urology and be a urology nurse, but I don't think that's going to happen.
So shall we hand over to you, Lydia, for the discussion on the next slide?
Thank you, Tracy, and thank you, Neve. Yes, so I'm reaching out to you now, the audience. Do you have any questions for the speakers? What are your thoughts on these recommendations? How can we advocate as a community for implementation of recommendations? And what should our next steps be in those areas that require further research and explorations? So I have one question here for both of you. So it's from Compassion in Dying, and they asked, I would like to learn more about the support provided for ensuring that end-of-life care preferences are discussed and respected.
Sorry, could you say that again? I didn't hear that.
Yes, so it's from Compassion in Dying, and they have a question about end-of-life preferences and how we can make sure that end-of-life preferences are discussed and respected. So Tracy, do you want to address that?
Yeah, sure. I don't mind. Are you okay with that, Neve?
Yes, Tracy, yeah.
Sure. So I think one of the things that FPC has always been is the voice of patients. And I think as part of that, patients need to have their own choice. So they may have their own viewpoint on end of life care, what happens, what information they have. But I do think it's part of a wider discussion we need to have about the level of conversations that healthcare professionals have with their patients. And these are very difficult conversations often. And you get difficult questions like who will actually tell them. I know that the support services manager at Fight Bladder Cancer, for instance, has some patients who are on the forum who are on treatment that is really just life extending, but no one in their medical team has kind of had the discussion with them that it's not a cure. So they are talking about life, many years ahead, whereas realistically they're looking at probably 6 to 12 months. And I think that it's part of the same theme, really, of those hard topics, sex, lifestyle, and death, is very much part of that. We have to be honest. And I think we have to be honest, but in a kind and understanding way. Because again, it comes down to choices. If you know you only have 6 to 12 months versus a much longer period of a life that you are assume you're going to be treated and cured, you would make very different decisions. So my perspective, obviously, Andrew was diagnosed with a terminal illness in the end, which was bowel cancer, not bladder cancer. But we asked, we were very particular, and they were very reluctant to tell us at the time of no one can answer how long, but like, this is really it, isn't it? It's not going to be long. And it was really hard to get an answer, because I think it's probably one of the most difficult questions that a healthcare professional will be asked. But I feel like we need to provide more information, perhaps, to support professionals in having those conversations. And, I know there was an issue of Fight magazine a few editions ago that focused entirely on end of life care and that one. Well done, very good. And kind of decisions and those difficult conversations that you need to have. But one thing that I know from my perspective is having those conversations and understanding what was happening meant that Andrew had a better death. And I think that is kind of all you can hope for in that situation, because the sad truth is many bladder cancer patients do die. So to pretend that's not happening and not have those conversations is failing them. And they're a large proportion of the patients that we support. So that's kind of my perspective.
Thank you, Tracy. Neve, do you want to comment on this issue?
To be honest with you, when I first got diagnosed, I actually put all of that completely out of my head, just put it away, and I've kept it away. So mostly, and so it's just I think a lot of, like, a friend recently got diagnosed with breast cancer. She said that was the first thing came into her head, but to me, it's just my personality. It's basically something that I'm not going to think about unless I need to. I know I'm a nurse, but maybe so. So I have, so that's me anyway. That's my personality, I would say.
Yeah. And a lot of patients are like that as well. And I think a lot of the issues around the charity and something we advocate for is choice as well. So if this is a topic, the same as sex, if these difficult topics, if you want to talk about mental health, if you want to talk about anxiety or depression or sex or pooing or weeing or death, then the conversation and the door should be open there. If you want to have that conversation, or you could just be like, no, I just I want to focus on my own life right now. I want to celebrate every day, and we just need to make sure that we give the communication tools to the patients and to the health professionals so that they can make those decisions. So I think we have Johnston as well wanted to comment on this. You're on mute. I will ask you to unmute.
Can you hear me now?
Yes.
Yeah, thank you very much, Niamh and Tracy. That was absolutely fantastic. There's just so much in there that strikes home with me. I just wanted to, I feel like Niamh as well, that I often just put it to the back of my mind. I don't really know, I don't want to know what's happening. But I find it difficult to talk with my family, and I just wondered if Tracy is going to be able to have any advice about how that can be better dealt with, because my family or my friends, I've had my bladder taken out, so you've had your cure, you look fantastic, so that's great, and yet I'm feeling, well, it might come back. How am I going to deal with that? I just wondered what they had to say about that.
I think from my experiences, it's interesting. So you generally have two camps of people in friends and family, like people who want all the information and people who want none of the information, and just to kind of carry on. And either of those is their personal way of coping with what's happening to you, someone they care about. And I think that it is hard. And however you feel about it is kind of right. For a long time, Andrew just didn't engage with the terribleness of his first diagnosis. So he had a stage 4 cancer. The only option was to have his bladder out. It was a very rare cancer, so wouldn't have responded to chemotherapy. So he kind of knew if the RC didn't work, that was it, last chance saloon. He had like a 6% survival chance, and he was like, I'm going to be in the 6%. And the conversation was over. And he didn't really talk about it again. He just focused on moving forward, and it enabled him to build this amazing charity and do incredible things for 10 years. I think when he was diagnosed with bowel cancer and the initial conversation was, we can't treat it, it was a different topic. So I think that purely from surviving, you don't want to spend all your time thinking about death with any cancer diagnosis. I know it flits across your brain all the time, especially in the wee small hours of the morning, which was when I used to think about it and wake up. But I do think that when you're given a terminal diagnosis, and normally there's a progression of information to get to a terminal diagnosis, because actually healthcare teams are good at making you understand things are getting worse. And within you, there is an understanding that your options are narrowing. And I think as that's happening, you start to come to terms with the idea that there may not be any options in the future. And that's difficult. But I think it's really difficult. I can only kind of tell you how it was from my perspective. And I don't know how I would be if I got told tomorrow I had a terminal cancer. I just think what we need to do is allow people to have the choice of those conversations. So one of the things I do think is lacking is overall in this country is conversations about death in general. And interestingly, after Andrew died, I've retrained and become a humanist celebrant because I feel so strongly that we need to be having conversations about death and choices and a good death. And that's something that everyone deserves. And that's why, part of this work on the Exemplar study has to be about end of life, because it is a reality. And people have their own ways of dealing with it. There are patients that I've met who just haven't wanted to know and will carry on literally at the cinema the night before, they sadly died the next day. But there are others who really want to change what they're doing and spend however long they have in the end doing something different. And it's about enabling all of those things to happen and either talk about it or not talk about it. So I don't think that really answers your question precisely, because it's so complicated and it's really down to individual personalities. But I think that if we can allow the conversation to happen, as Lydia said, if people want, that would be good, because I think it's a very, very difficult thing to bring into the arena, particularly with people who are newly diagnosed, which is already a shock from an illness they don't really know anything about. But if they're diagnosed at a very late stage, it's something that perhaps needs to be in the conversation somewhere.
Thank you, Tracy. Yeah, and I think we need to really be able to recognise that for people with a terminal diagnosis, this is a really important conversation. But we've seen that we know that there are so many success stories and so many survivors of bladder cancer as well. And, you know, we've got so many on this call and we've got so many on the forum as well. So luckily for most people who are diagnosed with bladder cancer, it's definitely an adjustment, but it doesn't mean that you do have to face this decision. And we do see many wonderful stories of survivorship after a bladder cancer diagnosis. So and I think something that the charity does very well is tailor our advice as well. So we've got specific patient information booklets and different advice and different bladder buddies for people facing different diagnoses. And we are lucky that for most people diagnosed with bladder cancer, they're able to live long and fulfilling lives. So that is definitely good news.
Sorry, can I just pick up on that, yes, Lydia, briefly as well? So just to come back on what Lydia's just said, that's so true. And that's why in the magazine there have always been stories of people jumping out of planes, running marathons, going on hikes, going on expeditions across the world, many of them after they've had their bladder removed, you know, and had a difficult diagnosis. And there's a particular patient information booklet called Surviving Bladder Cancer, because often when you're diagnosed with cancer, you think that's it, that one there. It's like you prepared for this earlier, Lydia, it's brilliant. Because I think that's so important, because it, you know, it is a difficult illness, but as Lydia said, the vast majority of people will have a long and full life, either with bladder cancer or recovering after bladder cancer and treatment.
Can I just say, so I think maybe a lot of people deal with it the way I did, because I knew after I had the TURBT that the consultant told me he got most of it out. I had to wait, obviously, for a CT scan. It was a matter of weeks. But so I was waiting for each stage. So I wasn't going to, I think that is the way that I cope with things in general. And especially when you're coping for everyone else, because it's such a huge shock. Like within a few weeks after my diagnosis, my sister was getting married. My family live all over the world, so it was like a really big deal. And she was getting married in Wales, so that was like one of the, you know, biggest events we had in a long time. So had all that going on too. I didn't want me to be like just the, you know, the bladder cancer patient at the wedding. Just wanted to be her sister. So I think a lot of people can just put things on hold and just, you know, I'll see what's going to happen, see what my diagnosis is going to be. It's not necessarily, you know, mine was T1 grade 3, so it was contained within the bladder, but it was a grade 3 of squamous cell. So, but I think that's probably, I don't know, I'm sure there are a lot of people think like that too. You'll just wait and see. Just wait until you take everything in stages. You actually learn to take things, you know, away from scan, away from results. You can cope. You can actually cope going along in that way of working. So I have not thought about that. I've put it away. It's going to stay there for a while.
Thank you, Niamh. Julia, I think you had a question for the panelists. You want to unmute yourself? You're on mute. I'll unmute you.
I can't see the question I posted, but I think I can remember what I was going to ask. I suppose just picking up, Tracy, what you were saying, I was just curious about what your thoughts, both of your thoughts were about what you think are the sort of barriers to being, you know, being able to have that shared decision making in your experience. That was my first question.
I think it's really not helped by the complexity of bladder cancer diagnosis. As Niamh was saying, you know, it's grade, stage, treatment, like everything is complicated. It's not like there are different grades, but the treatment is vaguely the same. Like the bladder cancer pathways are so different. I mean, they're complex when you know about bladder cancer. So when you know nothing about it at all, and you're presented with, in quite a short space of time, having to make choices on what's the best option. Of course, the immediate reaction of everyone is, I must keep my bladder. You know, I can't have this. I can't have anything chopped out. So I think it is enabling people to see that regardless of which treatment they choose, they can continue, and giving them help. Quite rightly, you, in your question that you've written, you've mentioned decision-making aids. I think they are really useful in the context of having a conversation next to them, because it's very hard to present that kind of decision as kind of a diagram of choice. Like, you know, a table, it's this or that, whereas around that is this huge other bits of impact. How will it impact your life? You know, if you're faced with an RC, do you have a neobladder or a stoma? You know, and then it's lifestyle. Are you traveling? You know, will you have problems with incontinence? You know, neobladder control. Is it better to have a stoma? Could you cope with having a bag on your side? So it's the complexity of it that I think is overwhelming to patients. I remember actually, weirdly, on the day Andrew was diagnosed, this is how little we knew about bladder cancer. So there's a poster on the wall behind them with a bladder and the little tumours in there. So it's like T1, T2, T3, T4. And they were like, oh, it's a T4. And we were like, all right, where's T5? And then there was this really awkward silence in the room where the team were like, how do we respond to that? But that is the thing. You literally know nothing. We knew absolutely nothing. And I think that all we can do to provide aids to help them understand, and not pushing people to make what is considered the right decision by someone else, you know, and that's something that we have to be very careful with on the forum, is that people can relate their own experiences. But again, that's different to everybody. Everyone has a different lifestyle, different expectations. People manage things differently. So I think we can do stuff to help that. But in the end, you can't beat, you know, a CNS just having a conversation about that person's life, because that helps them understand how different treatments will impact them. Because, as you know, as you and Heather said earlier, everyone is different, and it's your job as nurses to understand that individual and their life and their family situation, and on that basis you end up with the best treatment option. So yeah.
Can I just respond to that? I think you're absolutely right, and I think there's a huge education piece there. You know, so I am very aware, and especially when you were talking before about the palliative part of people's pathway, having some of those conversations can be very challenging, and people have had to have a good educational piece. So Hugh was talking about teams that work together, and it doesn't matter who does that. That their capabilities really do matter. It doesn't matter what professional title you wear. And I remember as a governance lead, so with part of my hat on, seeing things that maybe weren't going as planned. And we identified that for some patients at that palliative end, that individuals who were trying to support them, they would challenge themselves to be able to have those conversations, because those conversations are very difficult to have. And we put on a team day, so there was no sort of professional group or individual that, you know, could be seen as being singled out, but a really good piece by the palliative care team in sort of those advanced communication skills, and just took an element of a patient's story and how would we deal with it, and being able to do that in a very safe space, you know, where people can practice what that would feel like, what would it look like, how would I do that better, etc. And I think there's a big, we've talked about education previously, but I think that's for everybody. So
definitely.
Yes, and I'm following on from that. We have our final poll of the day. So this is about what is our top priority for action in the next 12 months. So I will launch that poll. So we've got three main options here. Healthcare professionals in all care settings should be supported to signpost everyone with suspected or confirmed bladder cancer to patient support services. Number two, patients must be involved in all major treatment decisions in line with national guidelines, particularly those with consequences related to final outcome, sex, and lifestyle. And number three, data on patient experience and quality of life should be collected, made public, and meaningfully used in quality improvement at the local and national levels. So I will share those results here. So we've got two here that are neck and neck. So the first is healthcare professionals should be supported to signpost everyone with suspected or confirmed bladder cancer to patient-supported services. And the second priority identified is patients must be involved in this major decision making. Patients must be involved in all major treatment decisions in line with national guidelines. Yeah. So this has been a really, really interesting and fascinating discussion. So thank you, everyone who has contributed throughout the session. So I think we've just got my closing remarks, summary of actions and next steps here. So first I will summarize the third session here. So what we've really heard from Tracy and from Neve is some of the challenges in telling family and friends about the diagnosis, the understanding that knowledge is power and can really help patients make informed decisions, that often patients feel quite alone, and that having peer support can really help that. That it's very important to have communication about long-term implications, that we do need to normalize talking about sex and pooing and weeing and living with a stoma or living with a neobladder, depression and anxiety. The fact, and also balancing the fact that while most people with bladder cancer do survive and live long lives, we do also need to have discussions with a few select people about end-of-life preferences. And the audience voted about what we thought were the priorities in terms of next actions, and improving signposting to patient support services was one of those priorities. And the other was making sure that joint decision making is really championed and that patients feel as if they are involved in all of their decisions. So next slide, please, Laura. So now I will try and summarize all of the discussions that we've had over the past couple of hours. So thank you for everyone who has joined us for this discussion. It's been extremely valuable and extremely insightful. And thank you for all the participants and everyone who's asked questions as well. So the first pillar that we discussed was about putting in place an exemplar pathway. And what were their priorities identified there were, one, about reviewing the national referral guidelines for GPs, especially when it comes to women, and making sure that we can catch more people early who have suspected bladder cancer, to look at TURBT and making sure that that is being classified correctly, to look into hematuria clinics, and also to have a national conversation on bladder cancer, to see if we can improve our 2-week rapid referrals, to make sure that there's more consistency between different regions, and to see if we can learn from prostate cancer and perhaps follow some of the best practices from there. And then the next session was session number 2, which was about developing and growing the bladder cancer workplace. And we had some discussions there, and we identified that some of the priorities there were mapping the number of CNSs that we have. And once we understand how many nurses and how many CNSs we have throughout the country, how many we need, then we can really advocate for the second priority, which was to grow the bladder cancer workforce, not only CNSs, but all the other specialisms as well that are needed to support people with bladder cancer. And finally, our third section was around improving patient support and improvement of care. And we talked there about the need for 2 main priorities, which was to improve signposting to peer support and patient organisations, and also to have greater patient involvement in treatment decisions and greater emphasis on joint decision making. So thank you very much for participating in this session. You can all go to fightbladdercancer.co.uk/exemplar and download your copy of the Exemplar Report if you haven't done so already. This is just the beginning of these conversations. Fight Bladder Cancer, we recognize that we are one component of this huge bladder cancer community, which is made up of many different stakeholders that we have here. We've got nurses, we have clinicians, we have oncologists, we have radiologists, we have different charities as well. We've got our industry partners and our amazing patient advocates and carers as well. So, and it's working with all of you and really having this national conversation with all of you and engaging all the different stakeholders that we can define an exemplar pathway. So I'm looking forward to many ongoing conversations regionally and nationally about how we can all fight for bladder cancer. Next slide, please. So you can find more information on our website, as I mentioned, fightbladdercancer.co.uk/exemplar. You can always contact us at info@fightbladdercancer.co.uk. Thank you very much for all of your attention and your contributions today. And I look forward to working with you in the future to make these recommendations into reality. So